Good evening, consultants, fellows, and colleagues. We welcome you to today's curriculum discussion, which will be led by Dr. Kofi Techi. He'll be presenting on bradyarrhythmias and pacing basics. We think this is a good continuation for SVTs, VTs, then I think Brady's following makes it a bit more systematic. So we are grateful for Dr. Asamoah stepping in to do this presentation. And so, Dr. Asamoah, please, your audience.
Thank you, Eugene, and good evening to everyone. I hope I'm audible enough to everyone.
Yeah, you are audible, Asamoah. Go ahead.
Okay. So today I'm going to attempt to give an overview of bradyarrhythmias and the basics of cardiac pacing. And we've seen that it's featured a lot in some of the MCQs that we've done, and we'll try and then go a bit more into some of the concepts. And so first we'll take a look at the conduction system, bradyarrhythmias, and then we'll look at certain issues surrounding pacemaker therapy. So we all know that the heart rate is very important in determining overall body function. You know that cardiac output is given by the heart rate times the stroke volume, and blood pressure is in turn given by cardiac output times total peripheral resistance. So that tells us that the heart rate directly influences one, cardiac output, and two, blood pressure. And therefore, abnormalities with the heart rate can result in hypoperfusion. Depending on the vessel bed that is hypoperfused, you may have different symptoms. So if you have cerebral hypoperfusion, you may have dizziness and syncope. If there's coronary hypoperfusion, it can result in chest pain, ischemic chest pain. If there's hypoperfusion to the peripheral muscle, then they fatigue easily. And the heart rate is also quite dependent on the integrity of the conduction system. Because when the impulse is fired from the SA node, the integrity of the conduction system is what results in the action potential being transmitted to all areas of the heart to maintain that output that is being sought. So just as an overview, here we have the cardiac conduction system. So this is the SA node, which is in the posterior superior portion of the right atrium. That's where the action potential is fired initially. Then it's carried to the left atrium via the Bachmann's bundle. Then it depolarizes the rest of the right atrium via the internodal tracts. Now this then comes to the AV node, which is in the inferior portion of the right atrium. Now in the AV node, its function is to cause a physiological delay in the speed at which the impulse is conducted. This is because when depolarization occurs, there's contraction. So by depolarizing the atria will contract. Now, if the AV node does not delay this contraction, then that means the ventricles and atria will contract at almost the same time, and therefore there will be suboptimal ventricular filling. So by delaying the impulse, it allows the atrial contents to be ejected fully into the ventricle. Then this impulse is conducted from the AV node down the His bundle, and then it then bifurcates into the left bundle and the right bundle. So these then innervate the myocardial wall and terminate in the Purkinje fibers and causes ventricular contraction. So this is an overview of the conduction system, which I believe we are all familiar with. This just shows the blood supply of the conduction system. So SA node is perfused by the SA nodal branch of the right coronary artery. And the posterior descending artery, which in about 70% of people arises from the right coronary artery, also perfuses the AV node and the junction. So the AV node and the His system. The LAD and circumflex accounts for the perfusion of most of the perfusion of the right bundles, and then the left anterior and posterior fascicles of the sorry, anterior and posterior fascicles of the left bundle. This is just here to make us appreciate that ischemic processes can significantly affect the conduction system. And so in patients who fit the profile, we should consider ischemic heart disease as a potential cause of cardiac conduction abnormalities. And then this is the ECG, which we are all familiar with once again. So the P wave here corresponds with atrial contraction, atrial depolarization. This PR interval is the physiological delay that is induced by the AV node to allow for ventricular filling. After which it passes the impulse on down the his bundle into the left and right bundles. And then that depolarizes the ventricles due to the QRS. Then we have repolarization, that's the T segment. And then in some people, you'll have a U wave, but then it goes again and then starts the cycle all over. So let's take a look at heart rate disorders. And in this case, you're interested in the bradyarrhythmia, so I'm not going to talk anything tachycardia. So the normal heart rate we know is 60 to 100 beats per minute, but clinically, we tend to be concerned if the heart rate goes below 50 beats per minute. Between 50 and 60, usually you wouldn't have clinical symptoms. If that is the only issue that there is, if there are symptoms, then likely there's something else going on in addition. And these bradyarrhythmias may arise either from AV nodal dysfunction or SA nodal dysfunction. SA nodal dysfunction is more difficult to spot on an ECG. On a surface ECG, those ones are much easier diagnosed in an EP study. And I'm sure we'll have a session on EP studies later where we'll look at the sinus node recovery time and the sinus node activation time. These would help us to identify the SA nodal dysfunction. But AV nodal dysfunction is much more easily recognized on the surface ECG. So when we talk of sinus nodal dysfunction or SA nodal dysfunction, there are two possibilities. Either, so that the sinus node is made of two types of cells, P cells and T cells. The P cells are the pacemaker cells, and the T cells are the transmission cells. Now, the pacemaker cells fire the action potential in the SA node, and the transmission cells are supposed to carry this impulse out of the SA node into the cardiac conduction system. So then you could either have problems within the pacemaker tissue, that's the P cells, or within the transmission cells, the T cells. And both of these would give you a sinus nodal dysfunction. And SA nodal dysfunction is in various types. So you can have a sinus bradycardia, you can have a tachybrady syndrome, sinus pauses, sinus arrest, sinus exit blocks, and contractive incompetence. Sinus bradycardia, we are all aware of what it stands for. You have a sinus rhythm, heart rate is less than 50. And sinus rhythm is defined as having an upright P wave in 2-3 and AV of the same morphology preceding each QRS. That's what we would define as a normal sinus rhythm. So if these features are met and the heart rate is less than 60, then we say that the sinus bradycardia. But as I said, 50 to 60 clinically is not really significant. Then we have the tachybrady syndrome or tachycardia bradycardia syndrome, and this is what we usually tend to call a sixth sinus syndrome. So now the tachybrady syndrome, what happens is that you have a sinus bradycardia, and because of how slow the rate is, at certain points, parts of the atria are able to generate an impulse faster than the SA node, and this takes over. So the most typical morphology would get to be a sinus bradycardia with an alternating fast atrial fibrillation. Sometimes you may have a sinus brady with a sinus tachy, but then so basically this occurs because the SA node is not able to consistently control the cardiac impulse generation. Now, the difference between sinus pauses and sinus arrests is that with a sinus arrest, the SA node stops, it goes to sleep completely. And then at a point, comes, it comes, it starts to fire again. So usually when we talk of a pause, it's just an issue of measuring the RR interval. It is stated that for you to have a significant pause, if you have an asymptomatic patient, then it's significant when you have an RR interval that is at least 6 seconds. Whereas if the patient is symptomatic, then an RR pause of 3 seconds is considered significant. So as I said, a sinus arrest will the AV node completely stops. Then you have the sinus exit block where you would have the SA node generating an impulse, and then all of a sudden you have a dropped impulse, and then it continues. So in a sinus exit block, what you have is that the interval between the RR intervals where there's a block is a direct multiple of the prevailing RR interval. I'm sure we see some examples going forward. Then the last one here is the chronotropic incompetence. What chronotropic incompetence means is that you have normally you know that there's supposed to be sympathetic stimulation. The SA node is highly stimulated by autonomics. So then you're supposed to have adequate sympathetic stimulation to match your levels of activity. So you'd expect heart rates to rise. So having chronotropic incompetence means that you are lacking this response. So your heart rate is not able to match your level of activity. And that is another manifestation of SA nodal dysfunction. So we've talked about sinus bradycardia, we've talked about sinus pauses, sinus arrest, and then tachybrady. So this is just going over what I've mentioned already. Now we come to the level of the AV node, and so we have 3 degrees of block. Now the first is the first degree AV block, and this is actually a misnomer because nothing is blocked. All that happens is that within the compact AV node, there is a prolonged delay or an excessive delay. And remember that I mentioned when the impulse gets to the AV node, it delays the impulse before passing it down into the ventricles. So in a first degree AV block, this delay is exaggerated. So then the PR interval is longer than usual. And normal PR interval is supposed to be 120 to 200 milliseconds. But in a first degree AV block, it's more than 200 seconds. A second degree AV block is in 2 types. There's Mobitz 1 and Mobitz 2. Mobitz 1 also occurs within the compact AV node, whereas Mobitz 2 occurs within the His and the infrahisian system. So with the Mobitz 1, you have a progressive prolongation of the PR interval. And then eventually the P is conducted with no corresponding QRS. And then the cycle starts again. That's what you have in a Mobitz 1. Now in a Mobitz 2, the PR interval is fixed. There's no prolongation. So you have a consistent PR interval wherever you have the P and the R QRS following. However, you tend to have more than one P wave to a QRS. So you have a patient who may have 2 P waves before QRS shows up, or 3 P waves before QRS shows up. And this is, as I said, infrahisian in origin. And once it's arising from the His and infrahisian tissues, that tells you that it is an unreliable rhythm and can easily progress to either a complete heart block or cessation of electrical activity, and that can have profound implications for the patient. So these people, generally, you would want to pace them even if they don't have symptoms. Third degree AV block means that the AV node is not conducting anything from the supraventricular conduction system. So the atria are beating at their own rate, the ventricles are beating at their own rate. And so this is what defines a third degree AV block. So as I mentioned, you may have a block within the AV node, or well, so you'd have the delay occurring within the AV node. This is what happens in the first degree and Mobitz 1 AV blocks. Then you can have blockages lower down within the His bundle or at the level of the ventricle. Now, when you have a problem within the compact AV node and actually up to the His, you would tend to have a narrow complex. Because if you have a problem in the compact AV node, when the impulses get through, it still goes down the His and then down both bundles. So you have left ventricle and right ventricle depolarizing and contracting at about the same time, which is why you have a narrow complex. However, when you have a block within the bundles, so let's say you have a block within the right bundle, now the impulse comes down and over here it gets blocked. So it depolarizes the left and then retrogradely then depolarizes the right. And so that results in a longer time of depolarization and then results in a broad QRS complex. And so the lower the block, the less stable the rhythm, and so you would want to pace this patient. So over here we have a look at this ECG. Here you can see there's a PQRST, PQRST, but here you realize that the the PR interval is about 2 big boxes roughly, maybe it's 9 small boxes. You see that it's consistent throughout. Consistently, you have that PR interval. This is what you have when you have a first degree AV block. First degree AV blocks usually don't require any intervention unless you have a PR interval greater than 300. Then that is where it is excessively prolonged and you may need to intervene. Yeah. Then here we have a phenomenon called group beating, where you see that we have a group of PQRSs here, and there's a break, then another group of PQRSs, there's a break, and another group. Now, this is typical of Mobitz 1 secondary AV block. Now, if you also look at the PR intervals, you realize that you look at this, and this one is longer than the previous one. This is longer than that. This is longer than that. Then here you have a P, and then there's no QRS. And then it starts again with a short PR interval. Now, sometimes you may not see the prolongation with each individual PQRS complex. And sometimes it may be difficult to appreciate the gradual prolongation. So an easier way of doing it is when you see this kind of group beating pattern, look at the PR interval after the pause, and then compare it to the PR interval before the pause. Once the one before the pause is longer than the one after the pause, it is a Mobitz 1 secondary AV block. That's a much simpler way of identifying it, especially if you can't really track the progressive prolongation of the PR interval. Here you see that there's P, PQRS, P, PQRS, P, PQRS, P, PQRS. So again, you see PR interval is the same throughout. And there are 2 P waves before each QRS. 2 P waves before each QRS. So this is typical of a Mobitz 2 AV block, a 2-to-1 AV block. You can have more P waves. You can have 3-to-1, 4-to-1, etc. Then over here, we have a P here. You have a QRS here, but you realize that there's a bit of a hump over here. You have a P, another QRS with a bit of a hump here. You see that there's no hump. The P has come out of the QRS. Here you see that this PR interval is shorter than this PR interval. Here you see that this T wave morphology looks different from this one. So Here you can see that you have just the T wave. Here you can see that it's fusing with the P wave. Here you can see that it's fused. Here you can see that it's actually peaked because the P is occurring within the T. So this is what we call the AV dissociation, and that is indicative of a third-degree AV block. So again, an easy way of picking up AV dissociation is that the P is not supposed to occur within the QRS ST segment T complex. So no P wave should occur within this complex. So if you see a P wave occurring within the QRS, within the ST segment, or within the T wave, then it tells you that it's dissociated. It's not obeying the natural law. And that tells you that there's AV dissociation, and so you think of a complete heart block. So what are the causes? It may be primary, as in degeneration of the conduction system, and so that's usually in the elderly people. And then it can be secondary to other things, like beta blocker therapy, hypothyroidism, ischemia, as we saw earlier, the bundles are highly perfused. Then electrolyte abnormalities like hyperkalemia can also result in this. When you have a bradyarrhythmia, first thing to do is check if there are secondary causes. If there are, treat and see if it resolves. I've seen someone who had a pulse, who had a collapse, came in with a heart rate of 35, and in clocking realized that she had been on carvedilol and 25 milligrams BD. So this was stopped, and then she came back for review. I think 3 days later, her heart rate was up to 70 beats per minute, and she didn't need anything. If this had not been investigated, then she probably would have ended up spending thousands of dollars on getting a pacemaker. So if there's no secondary cause, then you'd have to consider whether the patient is symptomatic or not. If the patient is asymptomatic and you have a rhythm that you think is infranodal, that is coming from the hiss and below, then you will still consider pacing, because as I mentioned earlier, rhythms from these areas are unstable. However, if it's coming from above, then there's no rush to put in a pacemaker and you can observe the patient. However, if you have a patient who has a symptomatic sinus node dysfunction, you're going to have to pace this patient. As I've said, infranodal blocks you have to pace. And then those that are symptomatic, even if infranodal, where your clinical approaches have not, your clinical interventions have not resulted in or have not resolved the symptoms, then you still want to go ahead and then pace. So now we'll take a look at pacemakers, having gone through bradyarrhythmias. And the pacemakers, basically their job is to ensure that you have a depolarizing impulse that is being discharged to whichever chamber is being paced to maintain a certain minimum heart rate. So the pacemaker system is made of two components. You have the pulse generator and the pacemaker leads. The pulse generator is made of three components. That's the battery, the circuit board, and the header. So here you have the battery down here. Now the hybrid, what is labeled hybrid here is the circuit board. So this is where all the electronic stuff are. So you have the capacitors and everything over here, resistors and all in here. And this is the header or the connector where the leads are connected. So this is the structure of a pacemaker, the same structure you have for a CRT or an ICD. So there are types of pacemakers. We have the single chamber or single lead pacemaker where you have just one lead. You have the wireless, the commonest. I don't know if there are other brands, but the commonest is the Micra from Medtronic. And then here we have the dual chamber where you have two leads. And then I think we'll have a tutorial on, we'll have a presentation on CRT later that would have three electrodes, so three leads, sorry. So just to look at certain terms, in terms of pacemaker, when we talk of sensing, is the ability of the lead to perceive intrinsic cardiac electrical activity. So that means that you have a lead in there and it can tell when you have the intrinsic rhythm that is firing, that is sensing. Oversensing means the lead is perceiving things that are not either things that are not from that chamber or things that are not cardiac impulses. So, for example, you could have an atrial lead sensing something going on in the ventricle. That would be oversensing because it's supposed to sense what's going on in the atrium, not in the ventricle. Similarly, you can have a lead sensing muscle contractions, diaphragmatic movements. This would be oversensing. Undersensing is the converse. So that means that the lead is not able to pick up electrical activity. So there's electrical activity, the lead is sitting there, but it cannot tell that this activity is going on. Impedance is also called resistance and is the sum of forces which are opposing the flow of current. When we talk of capture in terms of pacemaker, it's the ability of a pacemaker to deliver enough energy to consistently deploy the myocardial cells. So you're looking at a consistent depolarization that will translate into cardiac activity or mechanical activity. So if even it's able to cause some depolarization, but it's not able to sustain it to result in myocardial activity and mechanical activity, then capture hasn't taken place. And the threshold is the minimum energy that is required to capture. And in order to preserve or prolong pacemaker battery life, you want to use the lowest possible threshold. And because if you have a high threshold, it's delivering much more energy. So the battery is charging the capacitors much more, and so it's firing more. So the battery will run out much earlier. When we talk of inhibition, it's a response to sensing where the pacemaker senses the intrinsic cardiac activity and therefore does not attempt to capture. Whereas triggering means that the pacemaker senses, and because it senses, now it attempts to capture. So that's the difference between inhibition and triggering. So we have the pacemaker nomenclature. And so we all know the alphabets, and it's usually 4. Position 5 is not really used. So typically it's position 1 to 3. Sometimes you have position 4. So we have DDD, AAI, VOO, etc. Now the first letter talks about the chamber that is being paced. So if you have, for example, an A starting, then that means it's the atrium that's being paced. If you have a V, then it's the ventricle. If you have D, it's both that are being paced. Then position 2 is the one that is being sensed. So if the second letter is an A, you're sensing the atrium. If the second letter is a V, you're sensing the ventricle. If it's D, you're sensing both ventricle and atrium. Now, after sensing, how should the pacemaker respond? Should it do nothing? In that case, then it's O. Should it trigger capture? Then it is a T. Should it inhibit capture? Then it's an I. Should it do both trigger and inhibition? Then it's a D. And then for some pacemakers, you will have a rate modulation function where the pacemaker senses the body's activity and increases the rate of firing in line with the body's activity. So this is basically what the pacemaker nomenclature is about. So looking at single chamber pacing, we have a single pacemaker lead that's implanted either in the atrium or the ventricle, but it's not in both chambers. So it paces and senses. So it senses in that chamber that it is, it paces that chamber, and after sensing, it either triggers or inhibits that chamber. It's all about the chamber that is implanted in. Now, you can imagine that since it's a single lead that's being put in, the procedure is less cumbersome. You put one lead in, secure it, and then you're done. However, because everything is occurring in just one lead, it is less physiological. Now, when you have a single chamber pacemaker, the pacing modes, you can have an AAI, meaning it's in the atrium, it's sensing the atrium, it's pacing the atrium, but when it senses the atrium, it inhibits the pacemaker from attempting to capture. You can have a VVI, which means that it's in the ventricle, it's sensing it, it's pacing it, and when it senses intrinsic activity, it holds on. You can have AOO or VOO. This is what is termed asynchronous pacing. So in AOO or VOO, this means that it is pacing at a set rate. It doesn't care what is happening. It doesn't care about the intrinsic cardiac system. It is just firing, depolarizing impulses regardless of what is going on in the intrinsic rhythm. Then we have the AAT and VVT. These are not really used clinically. If anything, they are used to test the pacemaker when it's put in, but they are not modes that you would put a patient in and then send home. So when do we use atrium only pacing? If you have SA nodal dysfunction and you are certain that the remainder of the conduction system is intact, and you do not foresee that there's going to be degenerative changes or ischemic changes that would later also affect the AV node, you can do atrium only pacing. So this can be used for symptomatic sinus bradycardia, where you have an intact AV nodal system, or you can use it in a sinus arrest with significant sinus pauses. So that's when you would do atrium only pacing. So that once it paces the atrium, that impulse travels down the AV node to the ventricle and depolarizes it. The electromagnetic energy involved in MRIs and electrocautery can interfere with the pacemaker signaling system. If you have a patient who's going to go through these kind of procedures, then you put them in atrial only pacing, but it will be asynchronous pacing. So it's not sensing anything, it's just firing the impulse at a set rate. And then it can also be as a bridge to definitive therapy after lead failure. So you have a lead that has failed, you are planning to intervene. And so while you are planning that intervention, you are setting it to just keep pacing. Now, AAI versus AOO, the difference is that in AAI, the atrial lead is sensing intrinsic atrial activity. If it does not perceive atrial activity, it will capture, so it will pace. If it senses atrial activity, it will hold on, it will inhibit the pacemaker from firing or from attempting to capture. In the AOO mode, as I said earlier, it doesn't care what's happening in the atrium. You have told it depolarize every 1,000 milliseconds, which will give you a rate of 60 beats per minute. So it is going to do that regardless of what is happening. Now, ventricle only pacing. So if you have a third-degree AV block in a patient who has atrial fibrillation, you'll want to do ventricle only pacing. Reason being that if you are pacing the atrium, it's going to pick all these fibrillatory impulses, and therefore it is also going to result in ventricular fibrillation because everything will be transmitted down the ventricular lead as well. So you would want to do ventricle only pacing for atrial fibrillation. You can also use it for higher degree AV blocks where you are certain of a normal functioning SA node. However, the problem with this is that it could cause what we call pacemaker syndrome, where you may have the ventricular depolarizing impulse occurring at the same time as the atrial impulse. So then they end up contracting together, and in the end, there's no cardiac output, and that can result in hypoperfusion and cause syncope and collapse. Tachycardia syndrome, atrial fibrillation, this is essentially the same as the third degree with atrial fibrillation in terms of the explanation. And then also, just as I mentioned with the atrium only pacing, where you have electromagnetic interference, you would do ventricle only pacing. Dual chamber pacing result allows for communication between the atrium and the ventricle. So it is configured such that the lead in the atrium is sensing what's going on in the atrium, and then that then serves as an impetus for the ventricular lead to also kick into action. When you use this mode, you have a more physiological outcome because now everything in the ventricle is dependent on what is going on in the atrium, just as you have with a normal heart. In all our hearts, the atrium contracts first, and then the impulse goes down to the ventricle. That's what the dual chamber pacemaker seeks to mimic. But again, you have an extra lead, so that would give you a longer procedure time. When you use a dual chamber pacemaker, you'd want to use it if you have a patient who has a higher degree AV block, or those who have SA nodal dysfunction, who you anticipate may end up developing other conduction system disease. Then you can put in a dual chamber pacemaker. And then there are various modes. So you can have VDD, so the ventricle is being paced, but both are being sensed. And then when you sense, there's a trigger end inhibition. DDD, both chambers are being sensed, both are being paced, and then there's trigger and inhibition. DOO will be asynchronous, so pacemaker ventricle is being paced, atrium is being paced, pacemaker doesn't care about intrinsic rhythm. So when you put in a pacemaker, you need to look at certain timing cycles because pacemakers depend on the information you feed them, and it has to occur at a certain rate, which is what you give. So if you don't have good timing cycles, or if you don't configure your timing cycles correctly, then in the end you're going to have pacing without with your pacing outputs may not meet the needs of the patient. You need to remember that pacemakers only do what they are told. So garbage in, garbage out. It doesn't think for itself. Everything is based on how you configure it. So the first interval I'll look at is the lower rate interval, or the lower rate limit, or the base rate. Now, this is the minimum time that you set for the pacemaker to fire an impulse, and it is given in milliseconds. So to determine the rates, that's to convert it into beats per minute. It is 60,000 divided by the millisecond, divided by the time you want in milliseconds. If you want a rate of 60 beats per minute, then it's 60,000 divided by 1,000 milliseconds. So that means your lower rate interval will be 1,000 milliseconds. If you want a rate of 120 beats per minute, then your lower rate interval is going to be 500 milliseconds because 60,000 divided by 500 will give you 120. And then that's how it works. Now, the lower rate interval just tells you that at this time, send an impulse, and that is it. So this is what happens typically in the asynchronous modes. Once you have that lower rate interval, it is firing. But we all know that when you have ectopics, and we discussed ectopics, I think, yesterday. When you have ectopics and it occurs on the T wave, there's a risk of ventricular fibrillation due to the RONC phenomenon. So similarly, when you deliver, a pacing impulse and it coincides with the T wave, that's for ventricular pacing, it coincides with the T wave, it can degenerate into ventricular fibrillation. So that is a major problem of the um, the asynchronous single chamber pacing. Well, whether it's single or dual, that's the challenge with asynchronous pacing. Now we have the ventricular refractory period, which is usually it's the first 200 milliseconds after depolarization. And the reason for this is that even though the pacemaker fires the impulse, the lead may then go ahead and then sense the impulse that has just been fired. And so if it goes and then senses that, then it delays the next depolarizing cycle. So the ventricular repolarization period is a time when the ventricular lead is essentially turned off. So it cannot sense and it cannot sense the impulse that it has just fired. So that's the principle of the ventricular refractory period. So here, let's focus on the green one at the bottom here, where where the laser pointer is. So here you see that the ventricle has paced. Once it paces, it starts the lower rate interval. And then throughout the lower rate interval, there was no intrinsic cardiac activity. So it paced again. Then it started it again. Now, at this point, there was an intrinsic atrial activity, which eventually led to ventricular pacing. So because the atrial activity was sensed, it triggered ventricular pacing. And this occurred before the end of the lower rate interval. So then the pacing spike was fired here. So this would have been if it had gone all the way to the end. So then after this, then the new lower rate interval starts. And then you realize that over here, the ventricle sensed intrinsic activity. So once it sensed it, it's inhibited and then started afresh. And then that's how the lower rate interval works. And you see here that you have the ventricular refractory period here, ensuring that the ventricular lead does not go and sense its own impulse and then start another lower rate interval cycle. So that is basically how the lower rate interval works in principle. Now, um, when you have a dual chamber pacemaker, you want the two chambers to communicate so that you can have a more physiological output or outcome. And that's what we call tracking. So it's more, that's what we call a tracking mode. So then you're tracking what's going on in the atrium, and that's influence what's going on in the ventricle. And what happens is that when the atrial lead senses intrinsic activity, then it triggers ventricular activity, and that is what the trigger in the third column of the nomenclature means. So the atrium senses it. So let's look here. So here you have atrial activity, right? And then we have what we call the AV interval or the AVI. So it's a program such that once it senses something in the atrium or once it paces in the atrium, the AVI clock starts ticking. At the end of the AVI clock, if no spontaneous ventricular activity has occurred, then the ventricular lead will pace. Then you have the lower rate interval going. Here you have another atrial pace. So it starts the AVI clock. Nothing happened. So then you had ventricular pacing. Now here, it was not atrial pace, but atrial sense. And once the atrial lead sensed it, the pacemaker started the AVI clock. Nothing happened, so ventricular pacing occurred. Here, the atrium was paced, so the clock started. But before this person reached the end of the AVI, there was a ventricular impulse that was sensed. So the AVI was truncated, right? So in this case, the AVI was truncated, and then the ventricle was inhibited. So this is what is meant by dual triggering and inhibition. Inhibition means that in that in that ventricular in that ventricle, when the ventricular lead perceives ventricular activity, it will inhibit the pacemaker from attempting to capture. But when the atrium senses, then it will now trigger the timer to end up in ventricular depolarization. And so that is what the D in the third alphabet spot means. So the AV interval or the AVI is a fixed period following atrial activity, which will result in ventricular activity. And this is like the PR interval. So the AVI is doing the job of the AV node. As the AV node delays the impulse, the AVI is also giving a delay for adequate ventricular filling before contraction. And AVI may occur whether there's sensing or there's pacing of atrial activity. Now, there's another important timing cycle called the post-ventricular atrial repolarization refractory period, or for short, PVAP. Now, the PVAP is an interval here. So after the ventricle contracts, right? After the ventricle is stimulated, the PVAP is a period where the atrial lead cannot react to anything. And the reason is that when you have a ventricular impulse, it could result in retrograde P waves, because that ventricular impulse could conduct back up the conduction system into the atrium. Now, if the atrium senses that retrograde P wave, what's it going to do? It's going to start the AVI clock because it has sensed, and this will lead to ventricular repolarization. Ventricular depolarization. That also sends a retrograde P wave up. The atrium senses it, and the AVI clock ticks. So it establishes a cycle. But this is occurring very fast because the retrograde P wave will probably be somewhere in here. So in here, you're going to have the timing cycle starting. You probably have another QRS here, then the retrograde, and then it gives you a tachycardia. So this was referred to as pacemaker mediated tachycardia, or PMT for short. So the idea of the EVAP is that one, it stops the atrium from responding to retrograde P waves from from ventricular depolarization, so that you can have a normal lower rate interval to go through the cycle again to prevent pacemaker mediated tachycardia. Another benefit of the PVAP is that it is able to, the atrial lead does not respond to impulses, but it's quote unquote sees what is going on. So if, for example, you have a patient who has a paroxysmal atrial fibrillation, for example, during the PVAP, the pacemaker will be able to see that, okay, this person has developed an atrial fibrillation. And if I stay in this DDD mode, I'm going to end up in ventricular fibrillation. But the one who implanted the pacemaker puts in a mode switching protocol so that once it picks up that there's an atrial tachyarrhythmia, the mode switches from a tracking mode, which is the DDD, to a non-tracking mode like the VVI. Alternatively, it can stay in the dual tracking mode, but instead of a DDD, it will switch to a DDI, so that now when it is picking up those impulses, instead of firing with every impulse, once it picks intrinsic impulses, it holds on and then inhibits. So that's where the VVAP comes in. So this is just to explain the concept of the pacemaker-mediated tachycardia. So you have the what's it called? Ventricular spike. There's a retrograde P wave, and the atrial lead sensed it. So it started the AV interval. Then you had another one, another retrograde P wave, and then atrial lead sensed it. So you can see here A sense. So then, okay, so let's start from here. Here you have a P wave, a retrograde P wave, A sense. It starts the AV interval. You have V pace. Then retrograde P wave, A sense again, AV interval, V pace. So over here, you have initiated a pacemaker-induced tachycardia. But in this patient, there was the retrograde P wave, but this PVAP was increased. So this P wave, retrograde P wave, occurred within the PVAP. So even though it occurred, the atrium could not sense it. So it did not initiate a tachycardia. It was still going according to the lower rate interval. And then that is why you would have the PVAP there. Yes, so this is just to rehash what we've talked about. Then we also have the rate response. So every pacemaker has a rate at which it will induce a 2-to-1 AV block. This is because especially if you have a pacemaker that is tracking the intrinsic activity. As the heart rate increases, you may have impulses occurring within the PVAP period, and therefore because occurring within the PVAP, that P wave does not lead to a ventricular depolarization, and therefore you have an abrupt drop in the heart rate, and that can give you profound clinical symptoms. Imagine you are running and you're doing a heart rate of 120, and then all of a sudden this drops to a heart rate of 60 in an instant. This will cause significant clinical symptoms. So the way to do that is to set the upper rate interval a bit lower so that as the heart rate is increasing, then the PR gradually prolongs to induce a wanky back, and this results in a more gradual change in heart rate and is much more tolerable. This table is just a suggestion of the preferred pacing modes. Generally, you would want to do a dual chamber pacing if you don't have atrial fibrillation. You see here that atrial fibrillation is just DVIR. But in all the others, you would want to do dual pacing because it's physiological and would result in much better outcomes. Finally, we'll talk a bit about troubleshooting. So there's a phenomenon called crosstalk, where you have what we call far field sensing. So you have a lead in the ventricle. It's supposed to sense what is in the ventricle, but it is sensing the far field. That's sensing what's happening in the atrium. So again, this was referred to as crosstalk. So the atrium is talking across to the ventricular lead. And so an atrial spike ends up being detected by the ventricle as depolarization activity. So the ventricle will inhibit itself. So over here, you can see that you have atrial sense, ventricular pace, atrial sense, ventricular pace. Now, the atrium didn't contract, so here the atrium paced, but the ventricle sensed it as intrinsic activity. So even though the atrium had paced, because the ventricle sensed it, it kept quiet. The atrium paced again, the ventricle sensed it. Atrium paced again, ventricle sensed it. So you see that all through here, there's no QRS. So here you've got a pause because the pacemaker is oversensing because of crosstalk. And you can imagine what effect this will have on the patient. So this just explains the principle of crosstalk, of oversensing. To do that, there are other timing cycles that can be put in, and you can put in the post-atrial ventricular blanking so that there's a period where the ventricle is blind after atrial activity. So even though so when there's this atrial activity, because it's occurring within the post-atrial ventricular blanking period, the ventricular lead cannot respond to it because it is blanked out. This will help to prevent oversensing from occurring. Similarly, you can have post-ventricular atrial blanking, where you have a ventricular impulse and then the atrium cannot respond. This is because you can also have crosstalk occurring the other way, where the atrial lead senses ventricular activity. And the sensing means that there's an intrinsic beat, but the pacemaker does not see it. It doesn't sense it, so it will still fire. So here you can see that you have a pacemaker spike and then ventricular depolarization. Pacemaker spike, ventricular depolarization. Here you can see that there's a sinus beat, PQRS, but the pacemaker didn't see it, so it still fired an impulse. Just that because at this point the ventricle was depolarized, even though you have the impulse, there was no capture because the myocardium is refractory. Then you have PQRS. Ideally, this should have waited. So at this point, it should restart the lower rate interval. So you'd expect it to probably contract around here. But even though this occurred, it did not see it. So the lower rate interval rather started from this previous pacer spike and then delivered another one. So in undersensing, you are overfiring, and this would result in faster depletion of the battery and could also result in an R-on-T phenomenon, which could degenerate into ventricular fibrillation. Whereas in oversensing, you are underpacing. So your battery will last very long because you are not using it to pace, but you are losing ventricular output because it is sensing atrial activity. That's the danger with oversensing. So yes, oversensing will cause underpacing or asystole, and they may also misclassify tachyarrhythmias. Because if it's sensing it as activity, as ventricular activity, then it wouldn't really report it as such. And then undersensing can also cause overpacing. and may induce arrhythmias. So what do you do when you have issues with the pacemaker timing? Interrogate the pacemaker, look at the impedance. Now with the impedance, it's not the single figure, but it's the trend that you're interested in. So if you started with an impedance of 400 and now the impedance has jumped up to 1,200, that tells you that there's a problem. You should expect it to be around the same area. So if the impedance is low, you should consider the fact that the insulator around the lead may have been breached. If it's high, the lead may be fractured, and so there's resistance to flow. If it's been rising gradually, you should consider that maybe scar tissue has formed, so now um, there is more resistance or there's calcification, which is increasing resistance. You also look at the pacing threshold and the sensing threshold. You would want to do a chest X-ray for these patients to look at the contour of the leads and see where they are inserted. So this is just going over all the timing cycles, and I feel like talked plenty about it, so I'm not going to talk about this again. We've looked at it already. Thank you very much, and I'll take any questions. Thank you. Eugene, over to you, please.
Thank you very much, Kofi. Thank you for the excellent presentation. It is at the spinal level. So at this point, we'll ask for contributions and questions from our colleagues. And afterwards, our consultants and fellows on the call will also add their inputs. There has been quite a number of questions on pacing. Prof will take us in the intracardiac pacing, but this is on the Brady pacing principles, choice of pacemakers and modes. So please ask your questions. It's either we understood everything or Kofi has used the EP style to confuse all of us. Okay, there seem not to be any questions. Dr. Kweki, Dr. Chukwefio, any contributions to this presentation, please? Okay, so colleagues are showing appreciation for the presentation. Let's give us somewhere a thumbs up. So I think it seems to have covered all the necessary points. And so at this point, I want to say a very big thank you to Dr. Samoa for stepping in. I actually connected him to do this presentation. I placed the gun to his head that we have to do this. Fortunately, I was able to get him to do it. Thank you, Dr. Samoa, for doing this. So we'll move to the next session of the presentation, which is the MCQs. Dr. Charles Okori will moderate that. I'm asking a bit of to do something urgently. Let's kindly cooperate with him and also ensure that all the remaining questions are answered today. Thank you very much.
All right. Thank you so much, Dr. Asamoah. Thank you for an excellent presentation as always. And thank you for just stepping to our rescue today.